Just to give us a quick overview, this is the current information from our world in data. And we see the increasing cases in the United States. Brazil appears to be going down, Argentina somewhat up, Colombia and Canada way down there. But of course, these are the number of new daily confirmed cases, but it's always good to look at it per capita in terms of cases per million for the numbers of the population. And dear me, things are not looking good at all in Argentina. Cases are soaring up, seeming to sort of duplicate what happened in Brazil about a month or 6 weeks ago. Canada, even when we adjust per capita, we see that Canada's got much lower rates than the United States or Argentina. Do bear in mind this is a linear scale. So that this is kind of, I like linear scales because it's kind of, you get I can see it better than the log scales, which I find a bit difficult to interpret. They're not that intuitive. But this is a linear scale. So you can see in Canada that the direction is up, even although it's much lower than in the United States. So that's kind of an overview of the situation in the Americas, and you are very welcome to this video, as indeed you always are. Now let's have a quick look at Europe, where things are equally concerning. At least equal or more than really. So here we see the situation in Europe, United Kingdom. First of all, Italy and Germany. Now Italy was doing so well for quite a while, then things have started to go up in the last week or two in Italy. It's a pity, it had been doing so well, and it's looking like the rise is kind of built in Italy now. So it is concerning, and of course Italy suffered so badly during the first wave as well. A lot of deaths in Italy in the first wave. Don't want that one yet. United Kingdom, France, clear linear increase. Netherlands in terms of per capita increase, and this is despite the fact that in Netherlands, keep going on the wrong one, my apologies. This is despite the fact that in Netherlands there is very limited testing. The only people that are getting tested are those that are symptomatic and really need to be tested for their own clinical grounds rather than for collecting epidemiological data. So the real number in Netherlands quite a bit higher than that, I'm afraid. Second screen. Belgium high, and Czech Republic. Well, not only the numbers high, just look at the rate of increase. That is quite dramatic, doubling times there in the Czech Republic. New daily confirmed cases per million. So that first Europe graph was new daily confirmed cases per million. And this is as well, but this is kind of the rest of other places in the world really. Now India, the number of cases, it does seem to be going down. Pakistan, well, that's a blue line, which means that really we don't know. The testing and the reporting in Pakistan is just not good enough to get anything but a blue line on our world in data. And Bangladesh, again, I'm not convinced we know what's going on. But India, the testing has been fairly good, and there does seem to be a dramatic drop-off in cases now in India, which is encouraging for India. I'm not sure we know how to explain it, but it's good to see. Right, so a bit of more detailed analysis now that we can learn from. I'm going to start off with the Office for National Statistics in the UK. And there's some very important information that's come out that it is applicable to everywhere in the world. So just before we do that, in case my phone goes off, I think what we'll do is we'll just look at the COVID symptom tracker app where I am. If I can find the right screen, there we go. So I live in Carlisle in the north of England, and in my area 1,075 cases on the COVID symptom tracker app, and I don't need to report now because obviously I've already reported in for today. But do download this wherever you are. Remarkably useful. It is used in the United States now and Canada as well. New daily confirmed cases in the UK. That's the 4 countries in the UK. England, Scotland, Northern Ireland, Wales. 32,000 new cases in the day and 390,000 active cases. So very useful, and you can get more localized information on your particular area as well. So obviously I've been encouraging people to download that for some time now, but interesting, you just flick to it, get that information, zoom into your area, report yourself, and just feel you're doing something. Even if you're asymptomatic, it's still valid data. It's all this data is essential, and I'm assured the confidentiality issues are taken care of, and I think it is true. I know I'll get comments about that, but anyway, make your own decision. Now, the UK Office for National Statistics, published on the 16th of October. Always a delay, of course, 2nd to the 8th of October. Cases in the community in this week, 336,000 within the community had the infection in that week. And in that week, that results to the infection being in 1 in 600 people. Now, this is good data from the survey because it includes asymptomatic people as well. So that 1 in 600 is pretty accurate because this is a large sample size. They send samples to all parts of the country. It's done in a representative way. This is good quality data that we have now. Highest rate in older teenagers and young adults still, which of course is why the hospitalisation rate has not soared. Now the hospitalisation rate has gone up, but it has not soared because it's mostly this demographic. But we now know in the last week there is increasing cases in older people as well. So as we said a couple of days ago, the increase in cases in hospitalisations and in deaths is actually baked in. That is now inevitable, unfortunately, that we are going to see that. So estimates of the percentage of the population in England testing positive. So here we have the graph from May through to October, and these are the percentages, and obviously join the dots, the percentages are going up about 0.6-0.7% of the population, which makes sense because it's 1 in 600 people. So that is the graph in the UK, and in other areas of Europe, as we saw, it is even worse as we go into autumn time. And indeed, this is what we've been looking at, which I think it makes sense to call this the second wave now, to be quite honest. I think I'll start calling it a second wave. I mean, we could argue about whether it's the first wave or the second wave or continuation of the first wave. Really, it's a continuation because it never went away, but calling it a second wave is really quite descriptive because we have a sustained increase in cases. That's the key thing. Now, just a bit of data about England and Wales up to the 2nd of October. Deaths due to COVID-19, 390. Deaths 394.1% above the average total death. So that's the average. So we're slightly above the average deaths for this time of year based on the last 5-year average. Now, this does fluctuate quite a bit anyway, so I'm not saying that means too much. But in the context of this, it kind of does, because deaths from COVID during this week up to the 2nd of October, 321 mentioned COVID on the death certificates. That's 3.2%. So that 3.2% and that 4.1 figure aren't that far apart, really. Compared to the week before, where it was 215 deaths, 2.2% of total deaths for that week. But this is in the background of mostly teenagers and young adults being infected in the weeks before that because of this delay effect. And unfortunately, as we've said, with more older people being infected, that number will go on increasing for the next few weeks. Now, some information about infection control was interesting. Among those who've met up with people from outside their household, either indoors or outdoors, 82% said they always or often maintain social distancing. 17% who said they did so sometimes, not very often, or never. So we've still got this rump of people. And this probably applies to the UK and the United States, where we're in a situation where the vast majority of people are behaving appropriately, but you've got this minority that aren't, and of course that's all you need to propagate this virus. And that applies to Europe, the UK and the United States. This 17% has stayed much the same for the past 3 months. So we've got this hardcore of what we might call pandemic ignorers. stayed the same. Now, people who self-reporting face mask wearing while shopping. So you go to people and say, have you been wearing a face mask while you're shopping? And 99% say they are. So excellent. But when you ask people how many other shoppers are wearing face masks, that goes down to 87. So what this means is people are reporting that they are wearing a face mask more than they perceive others wearing face masks. And we know that face masks are critical. I'm not going to bother arguing about that anymore. So just an interesting mismatch there between self-reporting and observation of other shoppers. It's like the question, are you an average driver? Well, most people think they're an above average driver. I know I'm not. I know I'm below average, but I'm an exception. Where most people think they're an above average driver. So if you say to someone, are you an average driver? They'll go, oh no, above average. You know, it's but of course they can't be. Everyone can't be above average. So perception and reality, they're slightly different. Now, anxiety levels. Now, we have mentioned this several times, and one thing that's really concerned me, there seems to be an increase in suicides in quite a few places. India, there's been a lot of suicide. Even Australia, there's been a lot. There seems to have been an increase in suicides. Now, of course, I've dealt with suicides or suicide attempts on a daily basis for many years of my life, and it's always a difficult one. I mean, at work you just go into mode and do it, but if you've been touched by suicide, and many of you have been touched by suicide, some of you watching will have had a close relative who committed suicide, and it's just the most awful thing. The reproach, the recrimination, what did I do wrong? You know, and it's just a huge thing. And you know, if there's anyone that you're worried about, come alongside them and talk to them. You know, human contact is virtually always helpful. And the same with anxiety. Anxiety is a horrible, debilitating thing. And at the moment, very or somewhat worried in the UK. It's 3/4 of the population. You know, this is not good increase in stress levels. High anxiety levels, 33%. Now, the thing about high anxiety levels is, not only is it absolutely horrible to suffer from, it's debilitating. You can't do things. So all I can say is be aware of anxiety in those around you, and try and help people. And if you yourself are anxious, you know, the single biggest thing I think you can do to help yourself is to tell people. Because it's very hard. Anxiety is not admitting weakness. I have suffered from anxiety, and a few of you might not have done, but most of you watching this will have done. So tell people that you're going through an anxious period, and you know, the vast majority of people will understand, and that will help, and it will give them the opportunity to help you as well as you help them. So, but just be aware that the anxiety levels, if you're in the UK, are high. And I'm sure that applies wherever you are. Now, this one I've been going on about for some time, ethnic background and death. Now, England and Wales statistics. Now, this is hard data now from the Office for National Statistics. So this is the best data really we can get in the UK. So what is it saying? And this is important wherever you live. In Western countries, the United States, I think this is going to be a really important thing. Demographic, geographical, socioeconomic characteristics, multiple generation households, occupational exposures. All these socio-economic factors have been talked about. Now, you know, my first degree was in biology. My second one was in master's degree was in health science. You know, I've always thought in sort of biological scientific terms. And as soon as people started talking about the disparities between different ethnic groups in the UK, and indeed other places, everyone was up and down, jumping up and down about structural this, that and the other, and all these built-in sociological inequalities. And I said, just a minute, you know, let's only, you see, I was a psychiatric nurse for a long time, and the most fundamental, well, not for a long time ago, I trained as a psychiatric nurse. But of course, I've dealt with psychiatric conditions for decades. And the most fundamental mistake you can make in psychiatry is to assume that a condition is psychological before you've excluded the biological causes, because the biological causes can kill you. So, my sort of systematic way of approaching is exclude biological causes, then think about psychological, sociological causes. And in the UK, the opposite approach was taken. And my feeling is that that has resulted in unnecessary deaths. And that is a complete tragedy that people have jumped to socio-economic type explanations before eliminating basic biological possibilities. Because I've seen patients die several times because people assume that their problem was psychological, sociological, when it was a simple medical, biological problem. And that remains an issue, but thankfully the Office for National Statistics have come in with hard data on this. After adjusting for all of these factors, so their statisticians are so clever, they can actually account, it's absolutely brilliant, they can account for all these. And after adjusting for all those factors, increased rate of death in Black African, Black Caribbean, Indian, Pakistani and Bangladeshi ethnic minority background groups in the UK. So the increase in death is still there after these have been accounted for. In fact, I'm going to cross those out. This is after these have been accounted for. Such a pity that people jumped to the wrong conclusions. We did talk about this at some risk, I must say. It's difficult to talk about these things in the current climate, but it's just tragic that people have died while the wrong modalities of explanation have been promoted by certain media outlets, for example. Now, higher risk of heart conditions such as diabetes and heart disease in some ethnic groups. Could that be it? Is it just the comorbidities? Well, no, it's not just the comorbidities either, because that did not have a significant effect explaining ethnic group differences. So there you go. It's not the psychosocial, economic. It is not the comorbidities. Not minimising the magnitude of this problem, but that doesn't explain the high death rates we're seeing. Accounting for all of these things. Black African males 2.5 times more likely to die than those from white background. Black African females 2.1. Now, we know this is true of people of other ethnic groupings, but we can't give the figures because the Office for National Statistics don't. This is directly from the Office for National Statistics. So I'd like to say lesson learnt. I suspect it hasn't been. Now, one of the big factors I suspect is vitamin D deficiency. We know this is a bigger problem in black Americans, for example, than white Americans. The incidence of vitamin D deficiency is way higher. But I wanted to keep giving evidence for this. And of course, we've looked at this many times on this channel. But I found this one. This is a good one. Now, this is East Virginia Medical School. Now, they say this, direct quote, while there's very limited data and non-specific for COVID-19. So this is not based on hard evidence. And they're upfront about that. They're admitting that. The following cocktail may have a role, so may, in the prevention mitigation of COVID-19 disease. Now, what I would say here is it's always a risk-benefit analysis. So, but this is, I admire East Virginia Medical School. They've stuck their head well and truly above the parapet on this and saying this is what they think is a good idea. Now, of course, I can't prescribe on this channel, so the list I'm going to give you is from East Virginia Medical School for your consideration. Talk about it with your own doctor. You should always go through your own medical supplier before taking any medication. I have to say that, of course. I cannot prescribe on the internet, and obviously not. But let's look at what they're saying. Now, BID, that's American for BD. We say BD in England, in the UK, and it means twice a day. So they're saying vitamin C, 500 milligrams. That's a fairly large dose, twice a day. So that's a gram a day, fairly large dose. What I would say is if you are taking a largest dose, drink plenty of water if you're taking a largest dose of vitamin C. Now, East Virginia Medical School zinc, fairly high dose. When I remember, I'm taking 30 milligrams a day at the moment, but they're fairly high dose. That's what they're advocating. Now, melatonin, the hormone produced by the pineal gland that regulates sleep, wakefulness, and of course probably does slow quite a few other things. That they're advocating that. They're advocating melatonin. Now, in America, I think in all states you can buy that over the counter. Of course, in Australia, New Zealand, the United Kingdom, we're much too stupid to be able to take melatonin, and it's banned. You can't buy it. You can't get it over the counter. A lot of people use it for sleep modification, but we can't get it. You'd have to get it prescribed. Oh, I've forgotten one, haven't I? Let's go back. Quincertin. Now, quincertin, they're advocating that as a supplement. We'll come on to that in a minute, what that is. I'll just tell you now briefly. It's a plant flavonoid. But we'll come back to that. Vitamin D, they're advocating. So I'm taking 2,000 units a day, so that seems reasonable. Is what they're advocating. And famotidine, this is in the same group of drugs as cimetidine and ranitidine. They all end in dine, and they're what you call H2 blockers, histamine 2 blockers, and they reduce the amount of acid in the stomach, and that's been associated with prevention of COVID-19. But I'm not going to go into that now. It's a bit complicated. But I have got a lesson booked with a pharmacist to go into that in more detail. So quincertin, plant pigment. So the flavonoids are what gives plants their colour. So you've probably heard the expression "eat a rainbow," eat foods of all plants of all different colours, because they all contain different flavonoids. And the darker the plant, like dark berries, for example, the odds are they contain more flavonoids. So all very good for you. They're antioxidants and they do all sorts of good things. Eat food, not too much, mostly plants is the mantra. So this is a plant pigment, this quincertin. It's a flavonoid found in many plant foods. I'm going to tell you why this really grabbed me now. Okay, it's found in the red wine's not why it really grabbed me. Oh, that's an interesting observation. But for goodness sake, if you don't drink alcohol, don't start drinking red wine for health reasons. If you're drinking alcohol, then in moderation, then red wine might be better than other forms of alcohol, but we do not advocate people start drinking alcohol. Also found in onions, green tea, apples and berries, but it's also found in buckwheat tea. Now, I can't say I've ever tried this, but what really grabbed my attention is this tea, under different names, is very popular in Korea, Japan and China. Now, of course, this is a correlation. The fact that the cases have been more controlled in Korea, Japan and China might have nothing to do with buckwheat tea, but interesting. I think I'd like to try some. I'm going to look out for some when I go to the shops next. And it's called all these different things in Korea, Japan and China, where apparently it's quite popular. So, interesting. Now, while I was on the East Virginia Medical School, just a bit of biology before we look at a couple other places. This is a remarkably useful diagram. So here's the link to it. Let's just have a look at what it's saying. If I can fit this on. So here we've got the course of COVID-19 and general approach to treatment. So they're counting day one here as when someone is first exposed to the virus, when someone is first infected. So this period of time from here to here is the incubation period. Now they've only got 5 days here. 6 days is probably more typical, but we know it can be up to 14 days, and we normally say 2 to 14 days. But okay, it's just a graphic. Let's carry on with it. Now, viral replication is at its peak, they're saying, at about day 2 or 3 of someone being symptomatic. So starts off here, more and more, then the immune system gets rid of it there and there. So you can see here that someone is sort of very symptomatic from there, or very transmissious from there to about there. That's the most kind of symptomatic time. when the viral load is highest. So there's most viral replication going on there. That's when the viral load that they are breathing out is going to be highest. So we see that people are going to be most infectious from 2 days before they get symptoms, in the first few days after they get symptoms, up to about 7 days after they get symptoms. So that was interesting. But then starting here, we have the thing that really causes the problem, which is the immune dysregulation. So there's delayed innate immunity, so that's an abnormal immunity. The cytokine storm that's a macrophage associated syndrome, I think that is, MAS. Again, it's an immunological thing, T cell dysfunction. So all these are increasing problems with immunity. And this line here is representing the risk of death. If someone's going to die, the risk is going to increase with time, as we know, because of and we know about this lag effect. And we can see here that the risk of death is not associated with the virus. It's associated with the immune dysregulation. So I just thought that was a very useful way to express this up to day 28 here. And this is why they say here, in these early stages, antiviral RX is a medical way of writing prescriptions. That means what drugs is given. You can write it like that as well. That means prescribed in medical jargon. So that's saying antiviral drugs would be good. Not that we have antiviral drugs, but if we did, that would be a good time to give them. Whereas here, by the time you get to here, the amount of virus is much lower. So anti-inflammatory drugs are useful here, which of course is the steroids that reduce the inflammation. And here we can see it's quite safe to give the steroids, or well, as safe as it ever is really. It's never totally safe, because the viral load is down and the body's pretty well got rid of the infection by then. So this is a remarkably useful timeline. And here we have the clinical symptoms. So the most symptoms here we see, the classic symptoms are from day 5, which is the first day of symptoms. That's really day 1 of symptoms up to about day 11 they're saying, where are the classic clinical features. But here, because of the inflammatory effect, we get the shortness of breath and the requirement for oxygen. This is talking about the requirement for oxygen. That the oxygen saturations drop at 4 litres per minute on a nasal cannula, and the saturations go below 94% of oxygen. So this is the time when oxygen can be life-saving. This is what happened to our Prime Minister, of course. His life was almost certainly saved by giving oxygen during this precise time period. The progressive hypoxia. Hypoxia is the lack of oxygen in the blood. Therefore, all the tissues of the body become hypoxic. So there's not enough oxygen in the blood, there's not enough oxygen going to the tissues of the body, and of course that is going to damage the tissues of the body. And the other interesting one this does show is viral debris. And this can go on for much longer. So the trouble is with viral debris is the virus. So if you take here, for example, there's no active live virus replicating, but here and here and here, someone could still test positive because the respiratory system is clearing dead virus, which can still test positive on the PCR test, but is not infectious. And is no longer a problem. It's the inflammatory response to the virus which is now a problem. But during this time period, people can still test positive. So that did cause quite a bit of confusion. And of course, this can go on for much longer in some individuals. Ground glass infiltrates. This is kind of this ground glass infiltrate is the consolidation in the lungs. It's basically that saying the level of pneumonia. So the level of pneumonia tends to increase as time goes on into this most dangerous time period here. So thanks to East Virginia Medical School for that. Very useful. Do download it for yourself in colour. Fully available, fully downloadable, and an excellent explanatory model of many of the things that we are seeing and talking about with regards to the progression of the disease. Now, just a couple of things to finish. Reinfection, and then we'll look at a good news story to finish from Australia. Now, the idea about reinfection. So, initially it was thought that people could get reinfected because they were showing up with this viral residue. That's not reinfection, that's the same infection. But then there was a case in Hong Kong, 24th of August, I think it was. I think it was a 33-year-old man. And he had been diagnosed with the virus. The genetics of the virus had been tested. He got better. Then he appeared to be reinfected. And when they looked at the virus that was reinfecting him, yes, it was another SARS coronavirus 2. Well, the same SARS coronavirus 2, but a mutated form. So they were able to do what we call a phylogenetic analysis, look at the genes of the virus and see it was the same COVID-19 pandemic, but a virus that had changed and mutated. So not good, because it means people can get the virus twice. If people can get the virus twice, then this pandemic could go on forever. If people can get the virus twice, then what if the natural immunity is not conferring immunity against the virus? Why should a vaccine? So it looked like pretty bad news. But so far, there's been 24 cases in the world. I can't remember how many official cases there's been, but it's of all the millions and millions of cases in the world, 24 have been shown to be reinfection. Now, to be fair, that the bar for establishing reinfection is quite high. The genetics of the virus has to be taken the first time they're infected, and the second time it has to be shown it's a different one. So this is only where more sophisticated testing is available that this will be known about. But I think it's important to remember up to 24 cases in the world. I still expect reinfections to be very rare. And I suspect reasons for the reinfections we have had will come to light with further research. So this site here is interesting. This tracks it. So go onto that site. You'll see all the details, all the details of all the cases all around the world. Very interesting. Numbers, ages, dates, places, times, everything on that. Now, reinfection. So the first one, so there's 24 now. So there's been 24 cases of reinfection in the world. And there's been one death, sadly. Netherlands, 89-year-old lady, female, died from reinfection. This is the only death there's been from reinfection. The vast majority of these cases have been mild to asymptomatic. In fact, I think, excuse me, I think they've nearly all been asymptomatic, actually. So you get the impression I'm not too worried about this. This is kind of I see this as a bit of a scientific anomaly. I'm really not worried about this. But given there's so much in the popular press, I just wanted to give a perspective on this that hopefully will reduce anxiety levels. Because I still believe we're going to get rid of this altogether. Now, there may have been cases earlier. Well, I think that's inevitably true. There will have been some. But the testing wasn't there, or the phylogenetic testing wasn't adequate. May continue to be test positive for several months. So people can test positive for several months, but they're actually not positive. So that was the confusing. Without being sick or being infectious, we know that. It's just these viral residues. But in these cases, it's different. The viral genetic makeup is different. So we know they've been reinfected. It can't be explained through in vivo evolution. That's change of the virus in life. And that makes sense because, as we see from here, we would expect the virus to be eliminated. This is not living virus, so it can't mutate in the viral debris stage. Average interval between infection and reinfection, 73 days. But I am not particularly worried about this. Will we see more cases people are looking for? Yeah, we could see 100 cases, or potentially a few thousand cases around the world. But compared to the amount of cases there have been, I'm not expecting this to be significant. If the data starts proving me wrong, I will be the first to come back and tell you. But as of now, I'm not worried by that minuscule percentage. Right, let's finish on a good news story. Right. Australia had 12 new cases in 24 hours. All recognised, all quarantined. Now, Western Australia, great big chunk of Australia, Now I do apologise. Someone sent me this information in, and I've lost your name. So do write in and tell me, and I will put you on next time. Western Australia has now been COVID community spread free for 6 months. Wow. This is from a local resident, but it's consistent with what I understand. Restrictions have been eased over the months now, with almost no restrictions within the state, because of course the borders are closed. That's the state of Western Australia. Pretty much no mask wearing, but still have hand disinfectant stations at the door of shops, good, and social distancing rules at shops, banks, etc. So still some precautions going on in WA. The hard border controls are working well, so you can't get in, you can't get out without being quarantined for 14 days. And they're working well. It was the breakdown of this system that caused the outbreak in Victoria, of course. In Western Australia, it's working well. But now this is a powerful piece of information. They're still catching handfuls of positive cases of people trying to come back in from overseas and from other states, mostly from overseas, weekly. So without this 14-day monitoring, the pandemic would have run wild, potentially, through Western Australia. But because they've closed the borders and they're quarantining people that come in, they're catching them all. Otherwise, these people would have caused ongoing transmission. Catching infected crews on bulk carrier ships coming into the port, 2 recently from Manila. So again, trade going on. It shows that the normal trade, commerce can go on here, but with the 14-day quarantine for anyone coming in, and that has done the trick. Not rocket science, is it? Account for the incubation period of the illness, and you have a state, WA is huge. It's the whole left-hand side of Australia. It must be about, Australians will correct me, but I would guess it's about 1/3 of the land territory of Australia. It's a huge, certainly a quarter. It's a huge area. Mind you, there's not a lot of people in most of it, but but there's still, there's big cities. There's Perth and there's other big coastal areas. So yeah, dramatic success story. Now the one where the quarantine restrictions failed, shall we say, Victoria, looking good. 2 cases in the past 24 hours, 137 cases active, and I think we've got some data from Australia that I can show you. Yes. Right. So this graph shows the number of COVID-19 associated deaths for males and females by age group since January 20, and this is for all of Australia. So we see that, as we would expect, more men than women, but in the older age group, more women than men. And thankfully, very, very low figures in the child, teenager, young adult bracket for deaths. More men there, more men there, more men there, more women there, 80 to 90, more women there, 90 plus. Partly because at that age, women live longer than men, so a lot of the men have simply already died, unfortunately, from something else. Now, this is the current situation. Current COVID-19 cases in hospital and intensive care. In Australia, 18 hospitalised. That's the colour for intensive care, and I don't see it on the graph. Wow. No one in Australia is in intensive care with COVID-19. Impressive. Capital Territory is no one. New South Wales, 3 hospitalised. Queensland, 2. Victoria, 13 still hospitalised. Northern Territory is none. South Australia, none. Tassie, none. WA, none. And this is the Victoria graph. We know this. This was when the quarantine went to pot. The price has been high. And the enforcement in Victoria has been strict. But it's worked. And as of Sunday midnight, I think it is. So actually, that is probably about now, and it's probably been already. Actually, the Eastern Australia's must be about 14 hours ahead of the UK, something like that. Can it be 14 hours ahead? Anyway, it's loads of hours ahead. It's probably that time already. They're easing restrictions quite a bit, so they're allowed to, I can't remember, 25 kilometres away from your home now. I think you're allowed more mixing. General, gradual, progressive lifting of the restrictions, which is starting from about now, from midnight on Sunday. So good. Were the situation the same in the United States and through Europe? It is not. Okay, thank you for watching as always.